Welcome, class, to the final lecture series for drug literature and evaluation. This final week, we will be discussing applying drug literature to patient care, and a lot of what we discuss is going to be regarding the use of clinical guidelines in practice. The objectives for today are to differentiate between different levels of recommendations in clinical guidelines, to evaluate clinical guidelines using the M.A.A.R.I.E framework that was introduced earlier in the class, and to describe methods for applying evidence into actual practice. Let's start with a clinical dilemma. In this dilemma, you are a first-year pharmacy student and you've yet to take classes on pharmacotherapeutic approaches to patient care. Over the next 4 years and then your entire career thereafter, you will be continuously exposed to disease states and other situations that you have never heard of before. In this class, we've given you the tools and instructions about how to read and interpret individual articles and research papers. However, for most situations, you won't be able to read and interpret the entire canon of research before you make a decision for a particular patient. So the question is, what resource can you use to identify the optimal pharmacotherapeutic choices for various disease states most effectively? Where can you go to identify the standard approach of care for your particular patient quickly? This will take us directly to discussions about clinical guidelines. Clinical guidelines, if you've not encountered them already, will become your best friends throughout pharmacy school. What they are systematically developed statements to assist practitioner and patient decisions about appropriate health care for specific clinical circumstances. They're sort of the standard of practice for how we treat various disease states, and evidence-based guidelines come in many forms. They're not just clinical guidelines, although the ones that you will read mostly will be clinical. For example, if you have a patient with hypertension, you should look at the guidelines for how to treat hypertension. If you have an asthmatic patient, you should look at the clinical guidelines for asthma. Same thing for cancers or any other disease state, really, that you'll encounter in practice. There's more than likely at least one clinical guideline related to that specific disease state that will consolidate evidence and give a baseline recommendation for particular patients. All guidelines are not clinical. Some are community guidelines, so for instance, public health initiatives. There are now basic community guidelines for how to deal with lead-based paint or water pollution. There are also infection prevention guidelines for reducing transmission of TB or how to deal with needle sticks after injecting a patient that has Hep C or hepatitis B. Guidelines can even be more narrow. They can be on the hospital level. So for instance, many hospitals will institute institutional guidelines to direct care in that specific health system alone. As we go through this lecture, we'll apply this M.A.A.R.I.E framework that we learned about in previous lectures and that we've been applying throughout our activities ever since. So again, M.A.A.R.I.E stands for method, assignment, assessment, results, interpretation, and extrapolation. So from the point of the guidelines population, we'll look at how the evidence is gathered, how it's assessed, how the evidence is compared to one another, how the actual recommendations are made, and how those recommendations should be implemented in clinical practice thereafter. This slide is another example of the M.A.A.R.I.E framework and how it can be used to interpret clinical guidelines. You absolutely should not memorize this slide. It's strictly informational. If it happens to be useful to you later in your career, you can come back and look at it. So let's dig into the M.A.A.R.I.E framework and talk about the method section first. So we're talking about the purpose of clinical guidelines, or how guidelines select their target populations and from what particular perspective the guidelines are taken. Guidelines were originally developed as a movement that was motivated by the finding that many clinicians in very small communities had very different clinical practices, which shouldn't have been occurring. So differences in practice were often not based on evidence. And this is still widely prevalent today, and it's a major reason why we need more pharmacists and more evidence-based medicine more generally. But differences in practice may be prescribing different drugs, some of which may not be optimal for the same disease states. It could even be things about which patient should I hospitalize, which patients require surgery, and so forth. That's why there's so many different guidelines out there to try to standardize and guide practice from a critical and evidence-based standpoint. Originally, the Institute of Medicine laid out 5 key purposes for guidelines, and these include assisting clinical decision-making by patients and practitioners, educating individuals or groups, assuming and ensuring the quality of care, guiding allocation of resources, and reducing the risk of liability for negligent care. As you can see in reading these original purposes, they were mostly focused at individual clinicians for their individual patients. Since then, guidelines and the purpose of guidelines has expanded significantly. Nowadays, guidelines are developed for the full range of clinical activity from prevention of disease states through palliative care, and they're not just at the individual clinician level. Like we talked about a couple slides back, they're applied at the institution level and the population-based level as well as the individual patient level. How we could think about what a guideline is aiming to achieve and at what level is asking things, is it targeting the individual patient or clinician? Is it the institution or is it the community? So for example, colon cancer guidelines state that they aim to establish indications and screening methods for those at average risk of colon cancer. In this circumstance, that aim is targeted at individual clinicians making choices for individual patients. However, if they wanted to assess whether aspirin could be widely utilized for prevention of colon cancer, that would be more population-based level of decision for a broader group. Throughout this lecture, we're going to be going back and forth between the M.A.A.R.I.E model and an actual guideline to make it clearer in what we're discussing as we go along. So for this class, we'll be looking at the 2017 guideline for the prevention, detection, evaluation, and management of high blood pressure in adults. This is the most current guideline on hypertension from this group. However, there are other hypertension guidelines from other groups. If we use the M in M.A.A.R.I.E, which stands for the method section, we're going to look at the purpose of the hypertension guidelines. And in this guideline, they state under their intended use section that the focus is on medical practice in the United States. So they're trying to provide recommendations for patients with hypertension within the United States. And this is important because some medications are only available in the United States, and there are medications that are used around the world which may not be used in the United States. And therefore, when they were intending these guidelines, they were looking at how do we practice here in the US. They also mentioned that the guidelines are intended to improve patients' quality of care and align with patient interests. The guidelines are intended to define practices meeting the needs of most patients, but they go on to say that these guidelines should not replace clinical judgment. So not every patient will fall under the purview of every guideline, and that's why you still need all those other research articles to try to find an article and a study that matches your patient most exactly. The other aspect of guidelines that we're going to look at under the methods section is target population. So who is the guideline intended for? Guidelines can be directed at narrowly defined groups to very large numbers of individuals. Guidelines, like all other primary literature that we've read in this course, will have inclusion and exclusion criteria, which are important to consider. So make sure that you have the right guidelines for the patient who's right in front of you. For example, many guidelines that talk about the treatment for high blood cholesterol include only recommendations for patients who are not on dialysis, so patients without end-stage renal disease. They don't provide recommendations for dialysis patients, and if you use the recommendations in those guidelines for dialysis patients, you could be putting patients at risk and come to poor healthcare decisions. So in the hypertension guidelines, under the intended use section, we can see that the guidelines provide recommendations applicable for patients with or at risk for developing cardiovascular disease. So the guidelines are targeting an extremely broad audience. And then the last thing that we'll consider is the perspective. So who is developing and writing the guidelines, and why should we trust the recommendations? In terms of how to identify a specific guideline for a disease state, this is just kind of a helpful hint. It's often very useful when you encounter a new disease state as a student to use tertiary literature, which is things like textbooks from Access Pharmacy, like the DePiro textbook. In those texts, they will often identify the primary guideline and the primary organization that wrote the guideline for a particular disease state. So if you were to look up hypertension in the Tapiro textbook and go to the treatment section, they would talk about the ACC-AHA guideline. It's important to consider who's writing the guidelines because each organization that writes a guideline will have its own approach, its own priorities, and own biases. While guidelines will try to remain unbiased, biases can always sneak in and conflicts of interest can always be present in the authors who write the guideline. Different groups will also interpret evidence differently. For example, a group of cardiologists may interpret a drug's place in therapy differently than the manufacturers of the drug. One group is more likely to be unbiased than the other group. Similarly, some small fields like radiology may be prone to promote more radiologic procedures than other doctors who are not as dependent on income using radiographic procedures. And organizations can be government agencies, professional societies, nonprofit, patient-oriented groups, and then for-profit and not-for-profit providers. It's often nice to see when guidelines join groups across agencies. So having a government agency along with a professional society, along with a patient care group, helps to remain unbiased. In the hypertension guidelines in their methodology section, you can see that they are written by the American College of Cardiology and the American Heart Association Joint Task Force on Clinical Practice Guidelines. And their standards are taken from organizations including the Institute of Medicine. So the American College of Cardiology is a professional society composed of cardiologists, and the American Heart Association is a nonprofit patient-oriented group. So this is a really nice example of how a professional society is teaming up with a patient-oriented group to provide a more well-rounded set of recommendations and to have that patient perspective in there. The guidelines go on to say that the task force seeks to strive to avoid bias by selecting experts from a broad array of backgrounds, and that the ACC and AHA have rigorous policies and methods to ensure that their guidelines are developed without bias. But keep in mind, bias can always sneak in. So this concludes the first video, the methods section for clinical guidelines. In the next video, we will assess the next step in the M.A.A.R.I.E framework.